Hey there, welcome back to BI 233. We're getting into our second set of lectures on urinary. We talked about how absorption works in the nephron in our last lecture, and now we're going to and we also talked about filtration first and then reabsorption. And now we're going to talk about secretion, and then we'll go back to those things that we talked about last time and kind of put everything together. So let's go ahead and switch over to our notes and get started here. So this is where we left off last. Bottom of page, what is that, 11? I can't see it there because it's typed over. But we wanted to now talk about tubular secretion, kind of our third part of making and forming urine. And so this is where we actually are going to take substances that are in the blood and we're going to actively push them into the urine. They're things that we really don't want, right? Things that are causing some sort of problem for us because we have too many of them, or they cause damage to our body or whatnot. So potassium. You can't have too high levels of potassium. It can be cardiotoxic, for example. Hydrogen ions. We don't want a lot of those because it makes an acidic environment, and that can cause problems if our blood pH gets too acidic. Ammonium and other nitrogen-containing waste products are toxic for our body. Creatine, used extra spent from creatine phosphate. Those are things we might want to push out into our urine. And so, as we just said, this can help control pH because of the hydrogen ions and other things. And we'll talk more about that when we get to acid-base balance a little bit later. Those two go hand in hand. So the main thing you want to know about tubular secretion that I'll write over here, or maybe we'll write over here, is secretion is active and therefore needs ATP to work. All right, and if we look on the next page, we're going to see a lot. This, you don't need to memorize this, by the way, and there's a similar picture in your book. It is on page, I was just looking before I started to try to find the page number. It was on it's on page 992. It looks like this. We'll flip over to the book, figure 2517 there, and it's showing where things are being reabsorbed or secreted. So let's look at our notes and just highlight a couple things. And the reason you don't have to memorize everything is there's some things that are more important than others that I want you to focus on. And so one is we want to focus on sodium and water. So remember, water follows sodium if sodium's moving through in an obligatory way using aldosterone. And so that water leaving in the early part of the proximal convoluted tubule is obligatory movement. Now you'll notice that any arrow that leaves the tubule is being reabsorbed. So if we want sodium back, we reabsorb it in our blood, our water will follow. If we want chloride back, we reabsorb it into our blood and it follows. Notice that the arrows are showing whether something's active or whether something is passive. There are some active transports where we reabsorb things, like sodium. Remember, it's actively removed via the aldosterone stimulation, and water passively follows. So it's in blue. If we want amino acids and glucose to come back, we actively transport them. Okay, but notice anything that's coming in, we can put we can use a different. Hold on one sec here. We're having a little trouble there. Things that are coming in all are actively transported. And those are some things that we don't want in our body, and we want to actively get them out into our urine. Some drugs, ammonium compounds, extra hydrogen, for example. Those things are going to go out. All right. Now, and as we moved into the descending loop of Henle here, which is B, we see water leaves, but no sodium is leaving. However, this is still due to obligatory, so I'm going to write a little note here. This is still obligatory water movement, H2O movement. And you might first say, well, I don't understand, because when sodium leaves, water follows it. Well, sodium can't leave in this loop, this side of the loop. The walls are impermeable for sodium leaving. However, remember, there's a concentration of both sodium and urea outside, and that concentration is what the water is still moving towards. So there's still obligatory water movement, although, or even though, the wall is sodium impermeable, meaning that sodium can't leave. This allows us to get a lot of water out here without it getting excess salt and other substances. So in this part of the loop, that's really all that goes out, this obligatory water movement kind of going to the concentration gradients that are out there. Now, as we go back up the loop here in C, we will notice something different. Sodium's leaving. So sodium, we'll put it in the right color here. We'll put things going out. Sodium's leaving, and it can leave both passively and actively, but most of the time it's leaving actively due to aldosterone. But no water, no H2O movement, because the wall is impermeable to water. So this allows us to make the concentration gradient the sodium here, but remove the water in another location. We'll also be removing water when we get to the collecting duct in just a moment, using mostly ADH. So we also have at the top of the distal convoluted tubule a little bit of sodium leaving, again due to aldosterone. Notice chloride follows in this case. Remember, we have some things that will come along as well, like a negatively charged thing would be attracted to that positively charged sodium, so we do see that. But look what we see again here. We have more secretion where we're getting things, oh, excuse me, I lied. Not there, up there. Oh no, I'm right, yeah. We have more secretion here and here. The hydrogens are being secreted in. Some drugs can be secreted in. So again, if we want to get rid of those things in our blood, they're at really high levels, we'll actively transport them in. Then we get to our last part here, which is E, which is our collecting duct, where all the nephrons are kind of emptying into. Notice lots of things can move here. This is the last place that we can make any changes, so a lot can be changed. Okay, so we still have active transport of sodium, but small amounts of it due to aldosterone. We see secretion of more ammonium type nitrogenous waste. And then we also have urea and water. Now, urea and water are going out passively. Oops, I need to make that red. I'm trying to be good here. Make this green, green. And then we see that we're reabsorbing here both urea and water. And they're both happening passively. So what's happening there? Well, that's due to the ADH that we talked about in the last lecture, increasing the permeability of the collecting duct membrane or wall via increased aquaporins, right, which we talked about, these little holes. And urea leaves, or water leaves, and urea gets solvently dragged through. this urea also causes some of this concentration gradient where we get, as we go down, we get more urea leaving. It gets stuck here in the tissues, and we get these higher milliosmolar units, and we can then have a bigger concentration gradient, move more water out. So it's a really good way to get very, very, very concentrated urine by having a little bit of urea leave, get stuck in the tissues, and then that helps pull the water and makes the concentration of the water really high. So here, where we've got water movement. So how do we form dilute urine? How do we form concentrated urine? So normally we want to form concentrated urine, meaning that we want to keep water in our system. But sometimes if we have too much water, we want to have dilute urine, right? Our urine will be very pale in color. So how do we do that? Well, once filtrate has reached the ascending loop of Henle, it is dilute as it will become under normal filtration process. Okay, so as it gets to here, you remember water leaves here, and then as it comes up, it's impermeable, so it's as dilute as possible. So generally, but if we, so in the ascending loop, it's as dilute as it will become under normal filtration. But if we don't have any aldosterone or ADH, the urine will become more dilute. So think about why. We won't have a lot of sodium movement and water following, right, in all sorts of different places. So water will stay in the filtrate. And then right here, we won't, if we don't have ADH, we won't have water leaving through the aquaporins. And so that water will just go straight out in the collecting ducts, into the papilla, out into the minor and major calyces, and out to the renal pelvis and towards our bladder. So we need to have, in order to get this water out at these different locations that I'm circling, we have to have aldosterone present for obligatory movement of water, and we have to have ADH present for that facultative reabsorption of water, where urea follows. Okay, so if we don't see that, we're going to have dilute urine. So when we don't have ADH or aldosterone being secreted, urine will be very dilute. Okay, now we normally would want more concentrated urine so we can keep water in our body. And so if aldosterone and ADH are both present, it'll become more concentrated. Now, you can also think they do often work together. We mentioned earlier they're kind of like best friends, right? They kind of do things together all the time, but they don't have to. Let's say you wanted to only get water back, but you had eaten like a lot of salty snacks and you had a high sodium content. Well, you don't want to bring sodium back. You want to actually excrete sodium. So aldosterone would be shut off in that case because there'd be really high levels of sodium. However, we do want water to come back to kind of dilute all of that sodium that's in our body that we're trying to process, so ADH would still be released. So sometimes one will be released or the other one will be released, but a lot of times they work together, okay? So, so here in the ADH, this is where the osmolarity in the medulla goes up so much, and this is if we increase. Remember, ADH increases the permeability of the collecting tubules. So when we have that increase in permeability due to the ADH, water will osmotically leave due to this high concentration here that we see. When we see a lot of dissolved solutes, the water wants to go and dilute them. And so that's our facultative reabsorption. Okay. Now, your urine can't get any more concentrated than that 1200 milliosmolar because the water, if the filtrate is 1200 milliosmolar and the tissue outside of the filtrate of the collecting duct is 1200, then we're at equilibrium and there's no more water movement, right? So this is our maximum concentration amount. And another way to think about it is no more water reabsorption. We need at least a little bit we need a little bit of water to dilute all of these toxic chemicals like the ureas and the other nitrogenous wastes, and if we have excess salt or if we have hydrogen protons. So we have to have some amount of water in the urine to get rid of the dissolved solutes that are there. And the maximum is about 1200 because that's the maximum of the outside in the medullary tissue. And so we would be at equilibrium there. All right, so now let's think about a couple other things here. So we have, so what would happen if our blood volume went down? So let's say we had some problem with blood volume like hemorrhage or excess sweating, a really hot day, we had a lot of diarrhea or vomiting, losing lots of water. Well, that will decrease blood pressure, all right? So if blood pressure goes down and blood volume goes down, water goes down, this increases solute concentration, right? If we have less water, we're going to have, relatively speaking, more salt. We are going to then reabsorb lots of water as the body tries to compensate for this loss of fluid. So if we're reabsorbing lots of water, what's going to happen there? We're going to have ADH be released to get a lot of water back in to dilute this very concentrated blood that we've lost volume for. Okay, so there's one thing to think about when ADH would be triggered is if you are losing blood volume. Now, we want to talk about a couple other little things, nothing too crazy here, but a couple things about the kidney and the way we think about it. So renal clearance, the definition of renal clearance is the rate at which a particular substance is eliminated, cleared from the plasma by the kidney in 1 minute. All right, so the volume of plasma, which is completely cleared of a particular substance per unit of time, usually 1 minute. And we use this to look for like renal disease or problems with filtration. And I'm going to just put a little note here. This little part is just, you can read for interest. But the way we do this is we give a this naturally occurring polysaccharide produced in some plants called inulin. It's not insulin. And I'm going to write read for interest because this is more beyond the scope of our class. But and it completely clears, meaning that we don't reabsorb any of it. We get it out in our urine completely. So because it can be like a control, and we can compare things, whether they clear faster or more or less than inulin, and we can get some idea of if our kidneys are working correctly. Okay, so anyway, that's all I want to say about that. We're not going to go over it in any other detail. Physical characteristics of urine, most of this you probably know already, or when you did your urinalysis lab, you got this. The color can be from clear to yellow to amber, depending on how dilute the urine is. It's going to vary with concentration and with diet and with liquid intake. It can become turbid or cloudy upon standing because of bacteria or because of some pathology. Odor, usually it's going to be ammonia-like upon standing because there's a lot of ammonium compounds that liberate, but it could be fruity or sweet with diabetes mellitus. And you might remember that in that case, we were producing ketones, and those ketones were liberating off and giving kind of this sweet smell. The pH is normally slightly acidic. It doesn't have to be, though. Normally slightly acidic, and the ranges can be anywhere from about 4.5 to slightly basic. Some variations are due to diets. If you eat more proteins and have more amino acids, you're probably going to have more acidic urine. If you have more of a vegetarian diet, you're going to be closer to an alkaline urine. But again, that varies widely depending on what you're eating and drinking. Now, specific gravity. So specific gravity is the relative weight of a specific volume of liquid compared with an equal amount of water. And so basically what we do is the original way you do this is you use a flotation device that measures how many dissolved substance are in a liquid. And so when you put this flotation device in water, it will float depending on how concentrated the liquid is. Okay, so if you have some liquid with a lot of dissolved substances, the float will go higher, and then there's little marks, and you can read at the top of the water line what the specific gravity is. So if you have distilled water and you have no dissolved solutes, we say that it's 1.00. And then if you have any dissolved solutes, you go above that from 0.0001, and in urine's case, maybe all the way up to very concentrated urine, 1.035. So the higher amount of solutes, the higher the concentration of solutes, the higher the specific gravity. That's really the key thing. And we can use this, it doesn't tell us what's in the urine, it just tells us how concentrated the urine is. And this can be useful if you're using a drug that's supposed to maybe make the urine more dilute, and we want to over time watch and see if it's working. We want to see if someone's dehydrated, how dehydrated are they. So you can use this to do that. And you probably understand, if you've ever seen pictures of people like floating in the Dead Sea or the Great Salt Lake Sea, they float very high, they don't sink as easily, and this is because of the amount of dissolved solutes. They are very salty lakes. They are not fresh water, and they have runoff and other salts that are leached out of the rock surrounding them. And so when the fluid that they're in is at very high concentration, people float at a higher rate. So same principle is happening there. But that's all we need to say in lecture about it. There will be a little bit more in lab. Now, chemical concentration of urine, well, it's about 95% water. Remember, we can't get rid of all water. We need to have some water in there to dissolve the solutes. And so remember that. Even really concentrated urine is going to be mostly water. 5% of solutes are derived from cellular metabolism. We already talked about urea, deamination of proteins. Uric acid comes from nucleic acids. Creatine is from some nitrogenous substances in muscle tissue, right? Our creatine phosphate. And what are things that we would normally see in urea? Well, we'd see some of those things that we just said. We'd see salt, especially because we take a lot of salt in our body, so we get rid of it. Potassium we get rid of because it can be cardiotoxic. Excess phosphate ions, sulfate ions. We might see calcium, magnesium, or bicarb, but only if we have a lot of those in our blood. We have an excess. So generally, we don't. So that's something to think about. Like what is supposed to be there normally? What do we not normally see there? Notice things we didn't see there. We don't see glucose. We don't see amino acids. We want to get those back. We don't see things like red blood cells because they can't filter through unless there's some damage to our kidney. So, good to think about. Now, we're going to spend a few minutes here on other organs, and we're going to go pretty quickly through these. I might try to just put all this in one, this lecture. We'll see how we do. So we have the ureters or ureters. I've heard it both ways. I think both are fine to say. The ureters are transport the urine from the kidneys to the bladder, and you can see them both right here, right there, going down, and they are retroperitoneal at the pelvic cavity, so they're out in the cavity, and then they go retroperitoneal, and they go inside, back in the back wall. They also go down to the posterior part of the bladder, and they kind of curve like this. So one way to think about it is they kind of come down like this and go like that, and then enter the bladder that way. Okay, enter the bladder here. They kind of go like that. And this helps with backflow. All right, this kind of turning medially, kind of similar to how you have a little trap underneath your sink, so gases don't come back up from your sewer to your sink or your toilet. That little bits of liquid there will trap and will help with backflow issues. So the walls, there's 3 layers. There's an inner layer, which is transitional epithelium, which we also find in the bladder and the urethra, right? We have a middle layer, which has got 2 layers of muscle, both a longitudinal and a circular. And this is going to produce peristaltic contractions to propel the urine to the bladder. And then we have an outer layer, which is the adventitia. And remember, with adventitias, this means that it's connected to surrounding structures. And so this helps keep the ureters in place, this fibrous connective tissue layer. Okay, now on the next page here, or on the bottom of this page, and then we're going to describe on the next, are the urethras. And we have the male and the female urethras and the bladders. Bladders are up above there, you can see, and then the urethra. So we'll come back to this picture in a minute. These pictures, by the way, that I'm mentioning right now, this one is on page 1003. Page 1003. All right, and so you can take a look at those, and they're all filled in. And we might fill, I don't know if I'm going to fill anything in there. I may just show it to you. It's a little easier to see it filled in. But you can see both urinary bladders. There's slightly different sizes and shapes between males and females. They're down at the floor of the pelvic cavity, right? They're retroperitoneal also. So that's good to note. They're a hollow muscular organ. And they have the 2 openings at the base where the ureters are. We already mentioned that. And the structure inside, we have the inner layer, transitional epithelium again, right? When there's no urine there, they kind of gets all folded up, and we have some rugae, very similar to our stomach when it's empty. And then we have our middle layer with 3 layers of muscle, okay? All smooth. And the ureters are also all smooth muscle, right? There's no conscious control going here. And then the outer layer, again, is an adventitia holding the bladder to the surrounding structures. What does it do? It holds urine, and it can actually hold about 300 mils, and you'll start to kind of feel like you need to go to the bathroom, but if you don't, you can ignore it, and then it will expand more up to usually 200 to 300 more mils, and you can even maybe not use the restroom then, but once we get up to about 800 to 1,000, that's the point where pressure so much and discomfort so much you probably need to use the restroom. So that makes sense from our own experiences. Now urethras. So the urethras are these tubes that are lined with mucous membranes, and they are going to allow urine to leave the body. So the mucosa is very interesting because it changes as we go from the proximal end to the distal end. So look at these 3 changes. It starts out as transitional, where it can stretch. Then it's pseudostratified columnar. And we know that that has goblet cells to produce mucus. And then at the very opening, the distal end, is stratified squamous, which helps with abrasion and protection, right? So that kind of makes sense that it would change over time like that. There are some sphincters, and these are the ones that are on page 1003. Let's see if we can get over there quickly enough here. I'm going to skip ahead here in the lecture notes. There's a lot of pictures. By the way, so some of these pictures for urine concentration, you can read, they often are a little bit more complicated than what we want you to look at or know, but they're really helpful sometimes in trying to understand what's happening when where the water's leaving, where salt's leaving, all those things. So here we go. Here's our urinary bladder. There's our picture here. So let's look at this. We'll zoom in now so we can look at both. So the urethra is got these sphincters, and you can see them listed right here. The internal urethral sphincter. We have an external urethral sphincter as well. And this is within the urogenital diaphragm, which is in our pelvic floor muscles. These are skeletal. These are smooth, okay? And so these will open due to involuntary contractions, but this sphincter will stay closed until either we consciously choose to open it, or we've gone too far and your body takes over and opens it for you. So that's interesting to note those. Now the other thing you want to note is note the urethra size. So the urethra starts right here, and the male goes through the prostate, goes through the pelvic floor, and then goes out here through the penis. And so it's much longer, generally on average, maybe about 8 inches long from there to the end. And really we're only looking at about 1.5 inches here. And that is important to note, because this is one reason why there's a higher risk of urinary tract infections in females than males. Males have, since their urethra is so much longer, all right, it has a lot more of a chance to have mucus trap and render bacteria inactive. It takes longer for bacteria to make it all the way up that length in order to get into the bladder and infect the bladder. So so that's one thing that's very different between them. And then the other thing is that in females, the only purpose of the urethra is to conduct urine from the body. But in males, it has a twofold function, to conduct urine and semen. And we'll talk more about that when we get to reproduction. Okay. Lastly, urination is a process where it's a combination of involuntary and voluntary, right? So as your bladder fills and distends, it activates stretch and mechanoreceptors, and that triggers a reflex arc. And that reflex arc is shown here as number one. Okay, so we get stretch and we get a reflex arc right here, going up through the spine, sending messages up to the pons. Okay, and we're starting to sense fullness in the bladder at the pons area. Okay, and it's going to return either inhibitory or stimulatory impulse. So if you can't use the bathroom at the location you're in, you're going to put an inhibitory response there to say, okay, do not release any urine. And if you are in the bathroom, for example, you'll say, no, that's fine, and you can give a stimulatory response. So this, so those are either that's basically 2 here, number 2, and then it'll either go down to number 3 this way to sympathetically cause inhibition, or parasympathetically cause relaxation and contraction of the bladder. So parasympathetic fibers contract the trusor muscle, causing the bladder to contract, and we relax the internal urethral sphincter, and that is numbers 4 and 5. Okay, and urination will occur. However, if we want to inhibit, we are going to have sympathetic nerves relax the detrusor muscle. Don't contract it, don't contract the bladder, but contract the internal urethral sphincter, so no urine should move past. And these are number 3, number 3 and number 4. Okay, and then at number 5, the sphincter is contracted, and we're going to, because of conscious control in our pelvic floor, and we're going to have no urination. All right, last 2 things, and then we're done, is incontinence. So incontinence is lack of voluntary control over urination. very natural in babies. They don't have really good control of that external urethral sphincter yet, and they have to kind of learn that over time, which they can do very well. Sometimes if we see an older children in adults, it's usually due to either emotional problems or sometimes nervous system problems. So we have to find out what the issues are and kind of try to help resolve those. Retention's the ability to avoid urine and is usually due to an obstruction in the urethra or bladder. Now that doesn't mean an object, that could mean inflammation, that could mean an infection, and so we see things like UTIs, enlarged prostates, which are both of those, or in some cases prostate cancer, again, which usually is an enlarged prostate, that may be blocking urine flow. So, so that is our urinary lectures. Go ahead and this is one where the book has a lot of extra information, and for some people that's really useful because they can read the details about some of the urinary processes and how we get water coming back and how we secrete different things. For other people, it's almost too much info. And so if you're feeling that way after you look at the book and read it, really concentrate on what we put in the lecture notes. And we'll try to limit our scope of questions more to the lecture notes. But the book is really helpful because it has lots of great pictures and lots of details, and so you may find that useful. If you're also having trouble understanding, always contact your instructors, and we will go over things with you. So, all right, guys, thanks. Have a good day.